There is also a national strategy for the promotion of mental health, although there is a lack of application.
So the main axes of intervention for the national strategy for the development of early childhood in Tunisia are having a healthy family environment, the implication of the community, government commitment, and providing adequate training for competent caregivers.
These are some details about the axes of intervention of the national strategy for the development of early childhood. For example, from perinatal period to 6 months, it is recommended to continue the perinatal services to promote nutrition and breastfeeding, to encourage availability of parents for their children, and provide psychoeducation for parents. From 6 to 36 months, for example, it is recommended to enhance quality of domestic environments, childcare for working mothers, etc.
Some services have been included in this national strategy for vulnerable children, especially screening and care for children at risk for developmental problems or social vulnerability. In Tunisia, we have a child protection officer, which is an office charged with coordinating between mental health care services and healthcare services in general and the judicial system in order to protect children that are who are victims of abuse, neglect, violence, etc. Family and parental education also has a place in this national strategy. There are some projects trying to prepare for birth and parentality, and there are programs for parental education based on positive parenting. For example, there were 4 pilot programs implemented in mother and child units for around positive parenting.
Besides these national strategy, there are also some individual initiatives in some healthcare settings in Tunisia. For example, I would like to talk about our experience. We tried to implement a unit about mental preparation for future parents for birth and parentality in the mental health department. It is coordination, collaboration between mental health department and OB-GYN department in Montjislim Hospital in Tunisia. This is a pilot project. We have made several sessions with several pregnant women, but it needs resources in order to be more stable. And this is a real photo of a session with future moms in our hospital.
In conclusion, so in Tunisia, we have been lucky to have a well-established national perinatality program since the 60s. However, this program did not include specific interventions about mental health. Mental health was introduced in recent programs, and there are numerous individual initiatives in many health centers dealing with mothers or children, but there is still a lot to be done. And thank you very much for your attention.
Thank you for your attention.
Thank you so much, Dr. Zwafa and Mona. Thank you for taking us through how Tunisia is dealing with this issue and how Tunisia has worked out its own strategies. Our next speaker has inadvertently been called away on another engagement. So we will advance to Dr. Ramdas Wansingh. He's the Associate Professor of the Department of Psychiatry here at the All India Institute of Medical Sciences, Guwahati. He's also a perinatal mental health specialist and has multiple funded and unfunded projects for which he's worked on, especially in the community towards improving perinatal mental health outcomes. I would like now to request him to present about India and India's challenges and the strengths that we can see in our country. Over to you, Dr. Ramdas.
Thank you, Sharad. And first, I would like to thank our international speakers for giving the overview of Thailand and Tunisia. And similar way, we are going to discuss briefly about the perinatal mental health in India. So similar to the other low and middle income country, we are also having the burden of perinatal mental health issues in India. And we are actually looking at the national programs as one of the policy options to improve the perinatal mental health in India. Then we will also going to discuss the ongoing research, particularly the maternal mental health intervention in India, and what are the future direction for the researcher, both national and international. We will also discuss in my presentation. So most of the things my previous speakers has already discussed, that it is a very vulnerable period due to the major physiological, hormonal, and psychological changes. And it's the pregnancy and perinatal period increases the risk for the mental disorders. So in India, the overall common mental disorder, which includes depression, anxiety, somatic symptoms, is around 21.9% during the pregnancy, but in anxiety can be up to the 55.7 during the pregnancy period. When we compare to the high income countries, the prevalence in the low income country is relatively higher. That is around 15.6% during the antenatal period, and postnatal it is around 19.8%. So there are certain factors, and there are certain factors that are influencing the mental health during the perinatal period in India. The risk factors are the family conflict, abuse, financial constraint, complication during the pregnancy, unintended pregnancy, early marriages, then insufficient dowry or poor relation with husband or in-laws, inadequate social supports, domestic violence, previous pregnancy loss, and male child preference by their husband or in-laws. Whereas in India, we also, the previous studies has noticed there are certain protective factors that are there is increase in education, particularly higher education. There are supportive husband, employment, and there is also opportunity for the recreation. So with this, we are going to discuss why the perinatal mental health issue still remains undetected and untreated in India. This one of the issue is the low prioritization of the maternal mental health by our government, particularly the National Mental Health Policy of India 2014 and Mental Health Care Act 2017, but doesn't specifically deals with the reproductive mental disorder and their consequences within their ambit. And when we go to the healthcare level, during the routine ANC care, there is a non-availability of any standard protocol or infrastructure in the routine prenatal or postnatal care. When we go to the community level, there is a non-availability of the protocol for screening, classifying, and treating or referring the woman with the perinatal disorders, including the depression, anxiety, and somatic symptoms. Another reason for why this issue remains undetected and untreated is the human resources. We only have 0.75 psychiatrists. As per this is actually a very old figure, but we still have the very low number of psychiatrists and mental health workers. In addition, the prenatal care in India is provided by healthcare workers, particularly ASHA, Anganwadi workers, ANMs, staff nurses, and medical officers, but they are not trained in the mental health component. Further, there is a large treatment gap for all the mental disorder, which ranges around 70 to 92%. And there is no separate funding for the mental health component, even under the RMCHA, that is a reproductive child health and adolescent program, or in the or mental health, maternal mental health under the NMHP. So when we start discussing we actually have the two options to integrate the maternal mental health in routine care. So one of the option is a national mental health program, which was launched in 1982. The key objective of that program was to integrate the mental health with the primary health care, which is still challenging in India. And another program for perinatal mental health where we can include this component is the reproductive maternal newborn, child and adolescent health program. It was started in 1997 and then there was a subsequent revision. Under this program, there is established system of healthcare for the woman to safely manage their reproductive health, pregnancy and child health. These both options, we feel that cost effective and feasible and there is a minimum requirement, but a requirement of the additional human resources. So prior to going explore the policy option, we were going to discuss briefly about the National Mental Health Program, since most of the international speakers and our participants are not aware of National Mental Health Program. So this program was aimed to improve the mental health services in India, and the key aspect was to integrate. But the model initially the model lacked clarity and there was inadequate funding, and due to that funding there was a limited training for the human resources and there was no managerial skill at the community level that affected the sustainability of the program. So Government of India has revised this program again and again, and the revision was targeted to go for the most vulnerable and underprivileged population to decrease the distress, disability, and premature mortality associated with mental illness. So the goals and objectives and strategies under the NMHP was holistic, but the implementation was the weak. So overview of this NMHP was to reduce stigma, to promote the community participation, increasing access to the mental health services, ensuring the rights of person with mental illness, and integrate mental health in the different program like rural child health, self-motivating and empowering them in the workplace, and also improve the infrastructure, generating the knowledge and evidence for the service delivery, and establish governance, administrative and accountability mechanism. So to improve that, the government introduced the district mental health program, and in that the government has tried to implement most of the things, but there was no consideration for the maternal mental health or for the other person, all other person with the mental illness. So we see this as one of the option. But for that, we need the capacity building on the maternal mental health as a routine training package. But till date, there is insufficient funding for this national mental health program. And even in union budget, the mental health component receives around only 0.81% rupees, that is 73,931 rupees for the mental health. And out of these, only 40 crore is allocated for the NMHP, that is delivers the 90% of the mental health services in India. So it will be very difficult with this budget to start the capacity building for the maternal mental health in India. So there is another option we considered as RNCH program. The program we have already discussed a few highlights in previous slides. So another important feature of this program, there is a cash benefit scheme. That ensure the pregnant woman would attend their antenatal care visits regularly and prepare the institutional delivery over the home birth. So community healthcare worker like ASHA, Anganwadi workers, ANMs, healthcare workers are involved to improve the attendance in the antenatal care, and the cash benefits, which is actually provided for the 4 ANC visit, 2 PNC visit, and institutional delivery, we consider as a mental health professionals as a window of the opportunity for the healthcare workers to screen these women for the perinatal mental illness. And on this, in previous one research, we tried to use these windows of opportunity that RMNCH is providing. And we found that this is actually very feasible approach, both administratively and as well as cost-effective approach. So in India, we tried under the BINDP study, and in the South Africa, many researchers are trying to explore this option. So with this, we are going to discuss what are the interventions that are available to improve the perinatal mental health from the LMIC. So we have actually the 5 approaches with which we can improve the perinatal mental health. One of the approach is a preventive approach, then mother-infant interaction, multimodal approach, and psychotherapeutic approach, and integrative approach, either to integrate with the National Mental Health Program or RMCH A+ program. So what means by the preventive approach? Preventive approach is the aims to prevent the postpartum depression through the intervention during the prenatal period. And mother-child interaction approach improves the mother-child interaction to improve the child wellness as well as maternal depression. And multimodal approach, it involves the multiple components. It includes the psychoeducation, structured psychotherapy if needed. Then there will be the training of doctors, specialist supervision on the regular basis, as well as systematic monitoring of the clinical progress and treatment adherence. Psychotherapeutic approach mainly focuses on the psychoeducation, problem solving, simple behavior activation, which can be given in the individual or the group based. So these are the interventions which can help to improve the perinatal mental health in the LMNC. So we have the RMCH program as well as NMHP, and we see there are the 2 options to integrate the mental health component. And when we go try to understand in terms of administrative issues, as well as in terms of cost benefit analysis, feasibility. So in terms of cost benefit analysis, both options are cost effective. Only the thing in the RMNCH program, we have to include the mental health component, and we have to start the training of the non-specialist staff, also to start the referral mechanism, recruit the additional mental health professionals. But when we go for the NMHP, we have to just add the maternal components, and we have to just requires only brief training. So overall, the integration of the maternal component under the NMHP is more cost effective. There, when we go for feasibility, we have to just revise the current guidelines, screening procedure, establish the referral channel and training procedure for healthcare provider. But in NMHP, we have to improve the existing programs, and we have to collaborate with the maternal units. In addition, we have to prepare certain drug list, safe procedure approved for the pregnant woman. In terms of human resources, we have discussed in the cost benefit analysis that we will, in RMNCH, we have to recruit additional staff, training non-specialist staff, and training full responsibility, sensitization of the community on mental health issues. But most of this part is already covered under the NMHP. So in NMHP, we just need some training of some non-specialist staff like nursing officers or ANMs and Anganwadi workers, so that they can screen and refer that patient to the maternal component under the NMHP. Overall, both the options are sustainable, but RMNCH is more costly option compared to the National Mental Health Program. But sustainability, National Mental Health Program is itself receiving very low funding. So that issue is also there with the NMHP. So with this, we are exploring both the options, and we are also trying to make some hybrid model so that we can improve the perinatal mental health services in India. So we will briefly discuss what are the ongoing research in the maternal mental health in India. So one of the project is a BINDP project, and where I was the PI, and it was funded by ICMR, and we developed a brief module for the primary healthcare worker for screening depression, as well as providing the brief psychological intervention for mild to moderate depression in the pregnancy and referral mechanism for the severe depression. So you see that model is a little bit multi-model approach, and it was also integrative. It was tried to integrate the maternal mental health services with the OBGY department or pediatrics department. So the intervention was tested in the 3 hospitals, particularly tertiary healthcare centers, and one was a secondary healthcare centers. And this is one of the intervention which was actually tested in the higher centers. All other studies are conducted in the community settings. And one of the benefit of this intervention is it is tested in the 3 states rather than one particular state. It was tested in Maharashtra, Karnataka, Delhi, having the 3 different languages. And interventions were mainly on the psychoeducation, relaxation exercise, health promotion, focused on mother's mood and personal health, as well as mother-infant relationship and relationship of mother with significant others like a family members. Tool we used were the PHQ-2 and PHQ-9. Then another program that was conducted in the Goa is a Thinking Healthy program, which was a peer delivered. We called it as a THPP trial. It was conducted by the Sangha. And they tried to provide the psychological intervention by the trained peers. That is a Sakhi, which is located in that village. So it was a sample size was around 280, and the trial was executed with the help of self-peer seat assessment. Then during the ANC visit, that card was shown to the gynecologist who treat that woman, and if who is a tested positive, then that will be referred to the appropriate mental health services. And the intervention is found that has the moderate effect on diminution of the perinatal depression at 6 months postpartum, and also cost effective to deliver. So this was actually community-based study, which was tried to screen the woman for the perinatal depression, to refer the gynecologist, and then gynecologist will refer to the mental health professional, particularly psychiatrist. Another research was conducted in the Madhya Pradesh, Sihor district. That was not focused on the maternal mental health, but was improving the mental health care. So it was aimed to design the comprehensive mental health care for the community, and it has 4 service delivery packages like awareness creation, detection, treatment on 3 mental disorder: depression, psychosis, alcohol use disorder, and depression. They also included the perinatal depression. The intervention were the healthy activity program, manualized psychological treatment on the behavioral activation, psychoeducation, behavioral assessment, activity monitoring, activity structuring, scheduling, and activation of social network and problem solving. Overall, it has received the high rates of response, early remission, and recovery, but there was no impact of the treatment on their functioning of an individual. Another approach was done, that is a participatory intervention with the women's group. It was done in the Jharkhand and Odisha, particularly rural and tribal population. So participatory learning and action of women's group was focused on addressing the maternal and neonatal newborn health problems once every month, and there was around the 20 meetings. So the women were going to discuss their problems with each other. And it reduced the moderate depression among the mothers by around 57% in the intervention cluster in the 3rd year. Another program, another research was conducted in the Kerala. That is a community depression intervention program was conducted in the Trivandrum. In this research, the psychological intervention was delivered by the public health nurses, which was a junior, and the principal of the cognitive behavioral therapy. And they used the Hamilton Depression Score rating scale. And the intervention included a psychoeducation of the patient, caregiver about the nature, symptom of depression, validation, monitoring and symptoms, and relationship with the negative thoughts, behavior, and adherence to the medication. So these 5 programs are conducted, 5 research are conducted in India. And most of the results findings are encouraging, but we need more comprehensive plan for the India, and that is actually the take-home message. And the comprehensive plan should focus on the 3 elements. First, it should be on all the levels, whether it is urban or the rural population. Then there should be the mechanism to establish the reporting channel And there should be a system for the accountability, monitoring, and evaluation of the program. We need, there is a need of funds for IEC activities, improvement of the infrastructure, other program related activities. Then we also have to focus on the social mobilization so that we can reduce the stigma associated with the maternal mental health. Then IEC campaign by the community health workers, focusing on the importance of the mental health, why and how to seek help, and about mental health services offered at the different places and their benefits. We have also focused on the training and recruitment, particularly the non-specialist workers. Since we are going to include the mental health component, there will be the burden on the nursing officers as well as A&M and other people. Then we have to also organize the regular training, which we have already started training our nursing officer at the AIMS Guwahati. And gradually we are planning to start the services that will include all these three elements. So these are my references, and I would like to thank Dr. Sharad and all other speakers and participants. Thank you very much.
Thank you, Dr. Ramdas, for that very erudite explanation of how things have been done in India. And I think at this time, just a second. So you can hear me? You ready, Doctor? So we have Dr. Ira, who has joined us from Indonesia, and we request that he take over and share about perinatal mental health care from Indonesia, the Indonesian perspective.
Thank you, Dr. Sarat Philip. Thank you, Ramdas and DST for this opportunity. Okay, can I share my screen for the slide?
Yes, I think you can. Please try.
But host disabled still. Can you make me as co-host?
Yes, we're just doing that.
Okay.
Are you able to do that now? Please try.
Okay. A very nice presentation, Dr. Ramdas. It's very detailed. Today I will try to give some overview about the perinatal mental health in my country, in Indonesia. The overview of my presentation is about what is perinatal mental health, that all of the speakers that have explained about that before, why is it important, the prevalence and risk factor in my country, and what can we do. We know about the perinatal mental health is not about only for a woman, but also in a man. And there is like encompasses a range of mental health disorder, not only depression. And the importance of perinatal mental health is about both a parent and baby. For parent, there is a maternal well-being. We know change in appetite, difficulty sleeping is challenging for mother to take care of themselves and the baby. And for parent-child relationship, difficulty bonding with the baby can impact baby emotional, cognitive development, and physical development like stunting. And for the long term, children of mother with the perinatal depression will more likely to experience mental health disorder later in life, emotional and behavioral problem, and developmental delay and cognitive development disturbance. And we know the quality of the country is depend on the quality of human resource. The prevalence of perinatal mental health disorder in my country, in Indonesia, a study published in that found the prevalence of postpartum depression is about 17.3%. And then the Journal of Psychiatric Research in 2018 found the antenatal depression is about 21.8%. And the study published in BMC Pregnancy and Childbirth in 2019 that showed that anxiety in Indonesian pregnant women is about 13%. So it is about approximately about 20 until 25%. What is the prevalence and the risk factor? There's about the prior history of mental health disorder, lack of social support, stressful life event, relationship problem, substance use, and pregnancy and childbirth complication. In some journal, we found the lifelong risk factor is about the violence, and about the prenatal birth is about the lack of support, and in the postnatal is also about the lack of social support. And the protective factor is the have knowledge about pregnancy, have a steady job, and have a good and trustworthy intimate partner, and social support from the friend. So with Dr. Ramdas and Phon from Thailand, we start a study about the factor that impact of perinatal mental health in Indonesia. So a study, we found that there is a relationship between psychological trauma, family support, and personality type with the perinatal mental health disorder. That risk factor including hormonal change and preemie gravida. And some factor that we found, the first is about the personality, that neuroticism can cause a perinatal depression. The second one is the relationship between family support and perinatal depression. We found that 42.5% that they have family support, that they cannot, they have a low risk of perinatal depression. We also found that relationship between past psychological trauma with prenatal depression. Based on research using the traumatic event questionnaire, 35% of pregnant women had experience of childhood abuse, and women with childhood trauma have 4.95 times the risk of having symptoms of mental health disorder compared to women who have not experienced trauma. And from the demographic factor, we found that the characteristic of maternal age that have perinatal depression occur in age 1935, and they have primary education, and they work like as a working leader. So what can we do to prevent this condition? The first one, in the antenatal, we found that who booking labor before 20 weeks is better than they don't booking. And then we also found that who have stimulation and support before, like psychosocial support and parenting information, because there are so many mother that afraid they become parent because the information about parenting is very over in my country. And then the promotion of caregiving practice that also can prevent the perinatal mental disorder. And after birth until 6 months, we can do postnatal care and parenting information. And then after 6 months, we can do development screening and promotion of caregiving. So the key point of perinatal mental health in my country is four things. The first one is about the stigma and lack of awareness. So how to overcome the activity that we can do is psycho-educational program for family and community. I think the program in India we can adapt in our country. And then the second one is limited access to healthcare. Beside telehealth service, maybe the idea about brief psychotherapy for primary healthcare provider is very important, because similar with India, in my country, psychiatrists only 1,200. They should be serviced for about 250 million people. So it's very less of psychiatrists in my country. So the brief psychotherapy is like bridging for lack of psychiatrists. And the third one, the problem is about the cultural and language barrier. With training, I think we can make like, also bridging for the community. And the last one is about the partner involvement. One of the solution is psychoeducation for a husband or spouse. The conclusion is perinatal mental health is very important for mother, babies, and family. Addressing perinatal mental health is essential for improving the well-being of mother and babies and promoting healthy development and growth for family, community, and a nation. Thank you very much, Dr. Ramdas and Philip.
Thank you, Dr. Ida. Thank you for that presentation. Thank you for discussing about the Indonesian perspective and giving us a bird's eye of what's going on there with regard to perinatal mental health. At this point of time, I just want to announce that you may have questions for the panelists from different countries or from the speakers from different countries. Please put your questions in the chat and we will get to them. We will take them up during the question hour, which is there. We now move on to the next phase of our program, which is a discussion amongst other disciplines. Now, as has been pointed out by all four countries here, there is a shortage of psychiatrists. There isn't enough to go around. There aren't enough mental health professionals to provide the services wherever it's required. Aside from that, mental health professionals seeking help from them is also stigmatized. So what can be done to improve outcomes? So we are looking both at an access gap as well as a treatment gap here. So in this regard, we want to go to the other disciplines, the other specialists who also are involved in perinatal outcomes, perinatal wellness, and try and get their perspectives and see how we can collaborate with them. What can be done to improve monitoring, surveillance, reporting? What can be done to facilitate better outcomes with regard to perinatal mental health? So in this regard, we have an experienced panel here with us. I would like to introduce them one by one. We have Dr. Himanshu Malakar, who is the assistant professor here at the All India Institute of Medical Sciences, Guwahati. Dr. Lungan Rungnai, he is also with him in the department as an assistant professor. We also have Dr. Limalemla Zamir, who is assistant professor here at the Community and Family Medicine Department. And we also have Dr. Vipul K. Das, who is an assistant professor here at All India Institute of Medical Sciences with the Department of Pediatrics. I'm going to tell you about the organization of this panel. It's going to be in two rounds. The first round, we'll try and get inputs on what changes or modifications can be done for the training of specialties to include some aspects of perinatal mental health care, some aspects of perinatal mental health care delivery within these things. So I'm going to start off with Dr. Vipul and request him to kind of just inform us on what does he think as a pediatrician, as an experienced pediatrician, what would be amenable for modifications within the pediatrics training especially with regard to perinatal mental health care. I know this may not be directly related, but we're looking at the infant health, which is also going to have a influence on maternal mental health. Dr. Bipul?
Hello. Thank you, Dr. Sagar. Thank you, Dr. Sagar, for questions. Actually, the mental health in the mother can affect the baby's health in a big way. So there are lots of problems of perinatal problems in the baby. Perinatal from antenatal period, any mental health in the mother can affect the baby's health in terms of it can affect the baby's brain growth even, which can ultimately affect the future neurodevelopmental outcome in those babies. So mental health detection is very important, and mostly it is in the perinatal period. At any time it can be detected. So in the neonatal period also, it can affect the neonatal babies. Mostly, the babies will not get proper care because of the problems with the mother. So anyway, the burden of the baby mother normally it increases many folds in the immediate postpartum period. So if the mother is having any perinatal period, then it can again makes the work more difficult for the mother to take care of the baby and herself. So again, the effect of this perinatal mental health in the mother will affect the baby's future outcome in the preschool, toddlers, and schooling is good, and later in adulthood also it can have many effect in the babies. So we should detect. There are a few problems we can the babies who are attending the pediatric OPDs for normally for vaccination or other newborn care, the well baby care clinic. So in that cases, we can detect the baby mother's problem from the baby's symptoms itself. We can get some subtle cues from the baby's problem. The baby may not be growing properly. So it is seen from the studies that if the maternal depression continues for more than 2 months in the mother in the postpartum period, so those babies, the weight gain is less compared to those babies born from with a normal mother. So that's why if after ruling out the organic causes for the not gaining weight, so another important thing we should look for is maternal health. And then if we get any abnormalities in the bonding, so during the bonding assessment in the mother, if we get any abnormalities or some attachment from the babies to mother, if the mother is not responding to baby's normal problems like a normal mother, or the not caring properly, not responding properly to the baby's hunger cry or any other problem, so then we can suspect, or if there is any injury the baby, unexplained injury, in those cases we can suspect that the mother might be having some problems, and we can definitely we should report to the families, as well as we should counsel them for the psychiatric or mental health checkups and obstetric cares. So likewise, so there are issues with breastfeeding also. Like already I have mentioned about the weight gain in the babies and less. So that breastfeeding is an issue because mother will not want to feed the baby properly, will not take care of the baby. In those cases, we can take help of express breast milk. We can counsel the father or other family members. So for that, so that they can properly take out the express breast milk and then feed the baby properly. Or we can take help from the weight nursing. So in those mothers, so weight nursing means any family members, if they are having any kids or breastfeeding babies, breastfed babies, so those mothers can feed the baby temporarily. Or we can take help if the baby is very sick, preterm babies, and mother is having this type of problems, so we can take help from the breast milk bank also. We can take milk from the breast milk bank. So these are a few ways we can handle the babies. And then we should definitely pick up those issues, and in any developmental problems in the babies. So we should think of some maternal problems or depressions as a differential diagnosis in the babies. Dr. Sarat.
Thank you, Dr. Bipul, for elucidating on how we can help better through improving infant mental health outcomes. So now I would like to take this opportunity to invite Dr. Himanshu to share his opinion on what aspects of training can be modified within obstetrics and gynecology so that more of focus is retained on perinatal mental health also.
The Sharat is mute.
Are you able to hear me? Hello, can you hear me?
Yes, we can hear you now.
Yes, yeah. So I would like now to invite Dr. Himanshu to inform us on how training in obstetrics and gynecology, especially as a specialty, can be modified or improved so that perinatal mental health outcomes also can be improved.
Yes, thank you, Dr. Sharad. So regarding training, I will like to add, I will like training to start from the obstetrician itself, because we are quite ignorant about mental health problem as obstetricians. As we know, these pregnant ladies, they will usually their first visit will be into the antenatal OPD, and it is the responsibility of the obstetrician to screen them for their mental health problems, and then to give them adequate directions and adequate referral to the psychiatrist or psychologist. But the problem is that the obstetricians are so busy in their own specialty, and considering that we have our other problems, especially in a developing country like India, like anemia and hypertensive disorders and all. So we usually neglect those small symptoms that the patient lady may present, which actually are red flag symptoms of mental health disorders. So I will like to actually sensitize the obstetricians regarding the mental health issues that can be and which is very prevalent among the pregnant antenatal ladies as well as in the postpartum period. After that, also training of the other paramedical staff is important, as well as the junior residents. Yes, here I will also like to add, like in ours, it is very important to identify those ladies who have mild symptoms, mild mental health symptoms, which were there before pregnancy, but that can be exaggerated during pregnancy or in the postpartum period. So these ladies are always at a high risk. So this is which is very important while taking the history of these patients in the antenatal period to identify those ladies, and for which our junior residents or our senior residents or even a nursing staff is of great help to us. So training in them is very essential. And another thing is that there should be a collaborative approach. It should be a combined approach from the psychiatrist, the pediatrician, the obstetrician. Everything should be in one roof. That will really help the pregnant patients as well as in the postpartum period. Yes, Dr. Sharad.
Thank you so much, Dr. Himanshu. Thank you for pointing out very pertinent points on training, which is there, especially in improving the CUDA. At this time, I would like to invite Dr. Lima Lamajani to inform us on what public health professional training could improve on with regard to addressing perinatal mental health and improving outcomes.
Thank you very much. As we all know, the situation is like the tip of the iceberg. What comes to the notice of the healthcare workers, what comes to the hospital, it's just the tip of perinatal depression, but the actual problems lie in the community. The whole picture is displayed when we go to the community, all the social problems, all the other related constructs. So also because the issues are not new in India especially, and I'm sure it's the same in the other countries as well. However, with the changing demographics and the population explosion, the resources are becoming scarce. So there is going to be an increase in mental health problems. So we would like to train our students on behavioral change strategies, because that is what is the need of the hour. We've been giving a lot of health talks, we do a lot of awareness, we make charts, we do role plays, but change doesn't happen. So we need to take the family as a whole unit and taking help from mental health professionals on how we can, uh, you know, conduct research, relevant research, conduct implementation research, do operational research, and bring evidence on what works in the field. adopt best practices, and advocate for integrated approaches. So we would need to actually step up, because the public health professionals are required in both academics, research, development agencies, and they also play a very important role in policy. So with this, I would like to say that definitely the time has come for including mental health care strategies, and using mental health care strategies in advocating community, uh, awareness, and all these implementation strategies for reducing perinatal problems.
Thank you, Dr. Limalinda. Now, I would just like to invite Dr. Lungan Dongmai to share her experience and her thoughts as an obstetrician and gynecologist. What sort of challenges and changes does she have?
Okay, thank you, Dr. Sharad, for your question. Till now, what is the main practice is that in our obstetric and gynecological OPD, mainly what we do is we, as the patients, because of the patient's load, also because of the other obstetric and gynecological problem, we don't much address the perinatal mental health issue in our OPD. This is like we because of the burden of anemia and other obstetric complication, we don't much look into this perinatal mental health. What we can do at the most is we can sensitize all the obstetrician and gynecologists and other pediatrician, whoever are going to be involved in the maternal care. And also we can train what we can do at the most is like we can integrate this perinatal mental health care services in the MCA system. Also, we can also make a provision for the early diagnosis and the treatment of those women who have a perinatal mental health symptom. And also we can incorporate telemedicine for those women who belongs to the remote area, who can come to the clinics and hospital for getting their mental health care. So I think in this way we can spread the awareness, and we can do some good steps for taking proper care of the maternal mental health, so that we can reduces the burden of all those mental health problem in the society. Since at the present, if you ask me, my practice, actually we have encountered some patients complaining of not into the very higher state of mental health illness, but they may come with a symptom of like feeling low, feeling like less lack of energy. But in that case, what we do is we advise just a counseling part, and we give them a good reassurance, and we just observe them, and we might need to take the help of our mental health specialist, and then we refer them to the mental health specialist for a better care. Thank you.
Thank you so much to all the panelists. Between the people on this panel, there's almost 3 decades of experience in clinics, and we've been quite enriched to hear both aspects of training and practice from each of them. Though it was supposed to be divided up between training and practice, it seems inseparable to what I hear. And a lot of things have been said, and one common theme is that there's an increased need for collaboration, there's a need for broad-based consultation, there's a need on moving forward together, rather than looking at saying that this is not something that my specialty deals with, or this is something that belongs to another specialty. Because ultimately it's the end user who needs to get benefited from that. So at this point of time, I'd like to open the house for any questions or queries to any of the panelists. To all the speakers, I would request that you make yourself available people in the audience may post their question to any of the speakers. They may also feel free to unmute themselves and ask right now, and then we can take it forward. Is there any questions anybody would like to unmute? And if there's any challenges you're facing with regard to unmuting, you can always put it in the chat. Any questions with regard to whatever has been discussed today?
Hello, I am Dr. Daoud from Tunisia. Can you hear me?
Yes, Dr. Dawood, please go ahead. Please go ahead.
Yes, I would like to ask the panelists if anybody has any experience about the inclusion of the father in all of this process of perinatal care, and if any of you has any experience about that or has read about it, to share information about this topic. Thank you.
So during the presentation, I'd heard Dr. Ira also mention that. I would request him also to give his inputs. Anyone from this panel?
Hello. Hello. Yes, am I audible?
Yes.
Am I
Yes,
audible?
yes.
You are
Yes,
audible.
yes.
You are audible, Doctor.
Actually, the father's role is very important here. Like in our practice, we have seen patients who are supportive, who are being supported by their family, especially the husband. They have a very positive experience of this pregnancy and childbirth. That is why even Government of India has nowadays, even regarding childbirth and practices, Government of India has said that it is very important that the patient should identify the birth companion along with her during labor, especially, and that birth companion is most of the times the father of the child. So that he plays a very important role in supporting the pregnant lady and going through the different phases of pregnancy and childbirth and also thereafter. Yes.
Thank you, Dr. Himanshu. Anybody else from the panel?
Hello, Dr. Sir.
Yes, please go ahead.
The father's role is immense if we look from the baby's point of view. Mostly in like about kangaroo mother care and all. So even then, though it is named as kangaroo mother care, kangaroo mother care can be provided by any adult person. So likewise, so father's role is very important in taking care of the babies if the mother is having any perinatal problems, mental health problems. So we need to always take the other family members for their support and for their for the mother's benefit and the baby's benefit. So we involve the father most of the neonatal management and baby's management. So definitely father should be included in all other medical problems also. So we definitely do that in our all neonatal ICU cases management, or routinely also we follow that rule.
Thank you so much, Dr.
Thank you.
Thank you. Thank you so much, Dr. Bipul. So I'm just going to request Dr. Ira and to mention or share their experience and what their opinion is on this question.
Okay.
Dr. Ira, yeah.
Okay. I think the important is from the psychiatry is about the support, social support to the mother who have a perinatal condition, because the field of support is like the feel like acceptance about his pregnant, and when his husband or father not accept about this condition, the feel of rejected is like the root of why they feel like depression and the other condition about the psychiatric condition. Thank you.
So thank you, Ira. I just want to share my experience. In previous institute, we tried to include a father in this treating the woman with perinatal depression. But we face certain challenges, and challenges were that most of the times father was only earning members in that family. So most of the time he was not available to come and attend the OPD services and also take care of a newborn as well as the mother. So that challenges is very commonly encountered in low income country. So we have to also think about how we can improve services for these low income families, because it's not possible them to ask to come to the OPD services. So I think community expert like Dr. Lima and all other can think about this also. So that's my input. Thank you.
Dr. Lima, would you like to respond to that? If there's anything.
You need to look at the family as a one single unit, and during the daytime when we often go to the community, we do not find the fathers because they're usually at work, and sometimes they're also unable to accompany the women to the antenatal clinics. However, we do have field workers who are from the community, and they can work with these fathers to have a more proactive role in the well-being of the mother as well as the child. And another very important factor here is the mother-in-law, especially in the Indian society. And sometimes she is the decision maker, though she may not be the head of the household. So, taking this whole family as a unit, improving the interpersonal relationships, improving health communication is something that we really need to work on. And we would need an integrated approach, with a multidisciplinary integrated approach to develop a model where everyone in the family can participate and have a positive interaction in order to enable both maternal and child's well-being. Thank you.
Thank you, Dr. Lima. So over to you, Dr. Mona. Do you have any reflections on the responses? Anything that you would like to share from Tunisia?
Well, thank you for all of your responses. In Tunisia, we face pretty much the same problems. Fathers are either unable to come to the hospital with their wives because of work engagements, because of low socioeconomic conditions, or simply because of prejudice and because of cultural ideas dictating that childbirth and child rearing is a woman's job. And so just like Dr. Lima was saying, sometimes it's the mother-in-law who is the one who is more involved in the process than the father is. So there's a lot of work that we try to do with the mother, with the mother-in-law, with the father, in order to try and involve the father more in the whole process.
Thank you, Dr. Mona. So, are there any other questions from the audience? Any other questions with regard to what has been discussed?
I have another suggestion. We could meet the fathers where they are. We could plan programs where the fathers are available at their workplaces, because usually when we conduct programs for the mothers, the fathers are not able to join. So let us go where the fathers are. I think this would really help. And especially because in that setting, they're all together, they can discuss these issues amongst themselves. And maybe in that setting where they're all together, all the fathers, they might feel more open to discuss the issues that they face and also form support groups. Thank you very much.
Thank you, Dr. Lima. That was a very radical suggestion. I think this is something that needs to have some thought done on this regard. especially trying to think of, whether workplace mental health could also, when we're looking at the workplace, when we're doing mental health programs, it could also include some aspects of household mental health for the workers over there. So this is something that we can definitely think about and work on. Is there any other question, any other suggestion, any inputs? Would like to hear some reflections from the audience as well. So as I see, there aren't any more questions or any clarifications. So I'd just like to sum up this panel discussion. I think it's been quite fruitful and quite informative for me as well. I see that, all 4 countries and all of us disciplines have come together to kind of offer perspectives, and each has brought in their valuable insight into this problem and how it can be solved. All the countries that you see here today have shared heritages of adversity, of deprivation, of economic disparities, inequities in accessing health. All of these considered, most of our problems seem similar. And I think getting together, looking at different approaches like this would really make sense for all of us to improve outcomes. Now, not just mental health outcomes, not just perinatal mental health outcomes, but general health outcomes altogether. So with this, I will now hand over the proceedings to Dr. Pranjal Day.
Thank you, Dr. Sharad. Yeah. Thank you, Dr. Sharad. At the end, I would like to extend my sincere thanks to our Executive Director, Sir, Professor Ashok Purani, our Dean Research Madam, Professor Runmoni Dekaman, for their constant support and encouragement. I would also like to extend my sincere thanks to all the speakers and participants of today's session who have come from different countries. Also, with this, I would like to end this webinar and hope we will meet for the next webinar soon. Thank you.